continuación voy a presentar a un colega, el doctor Zoran Stankovic, que nos acompaña desde Serbia. Él es jefe del Centro de Formación Fiji en Belgrado, Serbia. Es actual presidente de la Asociación Europea de Ginecología Pediátrica y la Adolescente. Él nos va a tocar el tema de quistes y tumores ováricos como causa de pseudo pubertad precoz isosexual. Con ustedes el doctor Zoran.
Thank you for your kind invitation. And queridos amigos, in pediatric adolescent gynecology, I'm really happy to share this time with you, and I'm grateful to Professor Anna Maria Ricalde for her invitation, and thank you, Priscilla, for your very kind and very good presentation, and you saved me because now I have not so much to tell. I will go precisely on the topic. I have nothing to disclose, and I will share with you my personal experience from the last 26 years in this field, like pediatric adolescent gynecology. And I love ovaries. Ovaries are my priority in my work, but in this case, we don't ask ovaries to start working before the time, as Priscilla explained. And we know quistes and tumors. I find in literature a few tumors very rarely really created precocious puberty. But real important for us is juvenile granulosa cell tumor. And of course, the three kinds of quistes. And what is the difference between these quistes? You know what is the presence symptoms of precocious puberty, but what is the point? The point is that we have three options with quistes. Sometimes occur once or two times in the first 8 years of one girl. We can see quistes, ovarian cysts, autonomous. They create precocious puberty, but really they are not. They not really create big problems in diagnostic process and in the treatment. Hypothyroidism, we heard about that, and the most difficult for us is making operative. I always want to start with normal. The normal ovary is with a small volume, with few follicles, and the normal length of uterus is no more than 35-40 millimeters. And of course, the volume need to be calculated by 3 diameters. And we know that in neonatal period is 1 milliliter, in premenarcheal no more than 3 milliliters, and in adolescence 6 milliliters. And in our published papers, we put the cutoff for the normal ovary in premenarcheal girl in 10 milliliters. Some authors ask to be 8. Doesn't matter. The point is to compare the volume between two ovaries. And how we create volume? ABC and 0.5. So simple. I know many of us escape from mathematics during our practice, but no worry, it's simple. Why is important to use this option? Because you can see now difference. If you calculate only the diameter, and you can see the 3 centimeters diameter, and the difference with 8 centimeters diameter is almost 3 times. But if you want to calculate the volume between these two ovarian lesions, you can see the difference of 30 times or more huge volume of ovary. When we share this knowledge with parents, believe me, it's easier for them to understand, okay, doctor, you have the problem, my girl, and now 3 centimeters, 8 centimeters, no, escape from that. And this is the case of almost 9 centimeters functional cyst, And for me, the most important is that we can measure the presence of normal ovary which surround the cyst, because in this case, normal ovary is more powerful than the cyst. And what we can expect? Resolution. But you will see in all my presentations today, this slide, how often we really explore during ultrasound and report the presence of normal ovarian tissue surrounding the cyst or tumor. And I will speak more about the presence of normal tissue. In this case, when you see the fibrin changes, the cyst, you know resolution started. And in not more than 6 weeks, usually the ovary resolved the cyst and cyst disappear, and ovary was had a winner. And what's the point with this case? I saw a few patients. 3 of them was sent to me for surgical treatment because they have 3 or more cysts in both ovaries, and volume ovaries volume were more than 20 milliliters. And when they saw them on ultrasound with the diagnosis bilateral ovarian masses, bilateral ovarian tumors, lesions, I say to parents, no worry, we will measure the TSH, and this is simple. This is hypothyroidism. And with therapy of endocrinologist, we solved the problem in few weeks. This is really, for me, the most difficult with any of girls I saw, because it's not easy to create diagnosis, and you need to expect repeatedly. You need to expect repeatedly appearance of cyst. And this is one case of a 4-year-old girl, and we saw that time first the cyst. The problem was that she passed one surgery a year before that because she had some cystic mass in another ovary, and the colleagues go to surgically treat it because they have a fears from juvenile growth cell tumor, and the histopathology was functional cyst, and then in only one cyst start to appear recurrently functional cyst. And of course we found CLA changes, no dysplasia fibrosa, and the point that we use the treatment, we change many treatments, and we all are happy when she passed 11 years and we saved that ovary. How we can really save the ovary from McCune-Albright syndrome? We need to choose every of these combination, like the first line of therapy with letrozole, tamoxifen, the second line of maybe fulvestrant as adjuvant, but as Priscilla told us, we need to individualize therapy. And one of my new approaches in this field was punctation, because I was enough brave for 3 girls in our department. When they appeared with recurrent cyst a second time and third time, and we sent the blood to check for genetic diagnosis and say no confirmation of McCune-Albright. Then I decide, when the cyst is 6 centimeters or more, transabdominally with full bladder to punctate. I used usually needle for amniocentesis, and with needle for amniocentesis we took out the fluid and sent the fluid for genetic analysis, and confirm from that fluid we confirm presence of cells genetically changes. But for me, most important clinically is measurement of estradiol and CA125 from the fluid. Why? Because when you have neonatus with functional cyst in the first day of life, and you punctate the functional cyst in neonatus with 7 centimeters to escape surgery, you measure that too, and you will receive the results. So simple. A few thousand units estradiol, very high, and CA125, low, basic level. Doesn't matter. And it's very helpful to be practical and to save patients from unnecessary surgery. In these cases, we use that information. We published that a few years ago. And now, during preparation of this presentation, you can see in the dates, 2 weeks ago, this girl appeared in my office. She was 6 years old, and you can see the uterus glands, normal endometrium, and you can see the ovary without chance to punctate because some changes, I hope, fibrin changes start to be there, but please, por favor, don't forget the normal ovarian tissue is the most important. And I believe that in this ovary, normal ovarian tissue will win. And what is about tumors? The tumors are usually juvenile grounded cell tumors, and we put the juvenile grounded cell tumor as minimal invasive, not very invasive malignant tumor. And I prepare for this talk my results personal. I have seen 8 patients, 3 premenarcheal and 5 adolescent with granulosal cell tumor, which I personally involved in their surgical treatment, and 7 patients were referred to me after surgery. All of them in totally 15. And what I learned from them? This case is my first laparoscopically treated juvenile granulosal cell tumor, and I was proud in that moment. It was 2008, yes. And we saw the signs of precocious puberty, ultrasonography, complex mass, and we use this morphology index of Eland, volume of 70 milliliters and structure, and put the morphology index 6. We don't see normal ovarian tissue in that moment on ultrasound, and say, okay, inhibin B is high, okay, this is possibly juvenile granulosal cell tumor, create an annexectomy. So simple. Create an annexectomy, put in the box, and go out, and everything is simple. And what I saw in our practice, in all 8 patients, 3 premenarcheal and 5 adolescent, we performed an annexectomy. This is one of adolescents with juvenile granulosal cell tumor. They usually came with tumor more than 10 centimeters and complex. And then I received a few years ago these patients to reviews. She was 8.5 years old, pediatric endocrinologist in different town, not in my town, asked ultrasonography and create measurements of the hormones, and ultrasonography will be done in 2.5 months. I don't understand why, but during the summer, during these 2 months, without of ultrasonography, torsion happened, and I can't believe surgeon who create torsion give the parents the photos. Please don't do that. Never. It's no logic. In many, we can discuss if you want later. If we have time, we can discuss why it's not good to give this kind of photos to parents. And okay, after operation, in last 3 years, she is without signs of precocious puberty, without any problems, and she's growing. It's good. And we don't have any information regarding preoperative levels of inhibin or MSH. And what I want to share with you? This is strange situation. These 6 adolescents was sent to me after surgery because the colleagues preserved that ovary in all of 6 of them, and then was shocked when they received the histopathology finding of juvenile ground cell tumor. And during the follow-up period, we have no recurrence in any of these. And the last one came 2 months ago. She was operated in July, and I put for you this slide with left ovary after cystectomy, but it's not cystectomy, it's tumor enucleation, 20 centimeters. We don't have images from preoperative findings. We don't have levels of CA125 ASH4 because the adult gynecologist performed surgical treatment. He was so sure in his skills and performed laparoscopy and took out a tumor of 20 centimeter cyst, and in 35 minutes preserved that ovary. And now what? I performed, of course, transrectal ultrasonography to see better the follicles and no arrest of tumor in this moment. And we will follow up as the another 5 adolescents what I told you. And that pushed me to see again the photo from 2008. And now I'm not sure that I will treat it the same, this girl in same like the previous time. Why? Because now I'm most brave to see the presence of normal tissue. And now, with this knowledge, I can recognize the chance to preserve this ovary from juvenile gross cell tumor. And please, if you have the time, be in the next of my presentation, Future of Pediatric Adolescent Gynecology, and maybe the third one tomorrow, today afternoon, about teratomas. I will speak more about normal ovarian tissue. But this changed my approach for ovarian lesions. And the point is that when we see that sign, we should preserve ovary. Thank you for listening to this lecture. We share everything what we put in the agenda, and thank you for your attention.
Invitamos a la doctora Priscila.
Bien, vamos a dar inicio a la ronda de preguntas. Por favor, si tuvieran alguna pregunta, pueden levantar la manito y se les va a alcanzar el micrófono. Aquí el doctor. Sí, adelante, lo escuchamos.
Good morning, Professor Zohan. I would like to say congratulations for your lecture. And I have some questions about the state of your granulosa cell tumor that you talk about, and you do only the annexectomy. But it depends on the state of the tumor. You can do this, but you have advanced state, you have a problem with this. And also, you told us about the benign cysts. In our country, I'm from Brazil, my name is José Maria, and in the lectures, all the time we advise the physicians for not to touch the ovaries for the girls. Because you have a problem that you put the surgeries when you remove the cyst and remove the ovaries. And in the future, you have great problems with these girls, this woman. So thank you very much. I have 2 questions for you. One is about the tumor cells, and the another is maybe the home message for everybody: don't touch the ovaries. Thank you very much for your presentation. The first one was the stage of the granulosa cells. Yes, because you told you only you do the annexectomy.
Yes, thank you for the question. We usually can expect granulosa cell in premenarcheal girls with complex masses and with signs of precocious puberty. And it's easier for us if we have increasing level of inhibin B. In case we can see the normal ovarian tissue surrounding the tumor, for example, in this case of girl with 8 years, now with this knowledge, I will perform mini laparotomy, took out the ovary, opened the ovary, enucleate the tumor without any complications and without fluid going into the abdomen, and of course see the another ovary, no changes in every peritoneal or something to biopsy, and finish the operation. With this knowledge, I will perform that. It's different than I know in 2008. And everything I will explain more today in the lecture Future of Pediatric Adolescent Gynecology. The point is, for me, only on the presence of normal tissue. I stop work with fears, and I stop work like Jota Group and the other colleagues from adult gynecologists teach us.
Hola, ok. ¿Alguien más tiene otra pregunta? Sí. Acá la doctora.
Doctora Rodríguez, usted mencionó el uso de la medroxi progesterona también como una droga alternativa para el tratamiento de pubertad precoz. Es una droga que tiene un impacto en la parte mineral ósea. ¿Cómo es su esquema? ¿Qué tiempo? ¿Y cuál es su experiencia con respecto al uso de esa droga?
Gracias. Bueno, como les mencionaba, en un principio fue usada para tratar la pubertad precoz, pero actualmente se usa para inducir amenorreas, principalmente pacientes que no queremos que vean menstruación. Y sí, sabemos que tiene un impacto sobre la masa mineral ósea, pero esto extrapolamos los efectos que puedan tener en la anticoncepción y sabemos que en la pubertad precoz se usan por cortos periodos de tiempo. Y luego de suspenderlo, entonces se ha visto que retoman y que se recupera la densidad mineral ósea esperada. Es decir, que los efectos que se tienen no son significativos en cuanto a la masa mineral ósea porque se suspende prontamente. Con respecto al tiempo, pues entonces es las inyecciones de depósito trimestrales. ¿Y por cuánto tiempo dejarla? Pues si la indicación fue para inducir amenorrea, va a depender entonces de esta maduración y la parte psicosocial de la paciente, a cuándo entonces, por cuánto tiempo suspender la menstruación y cuándo entonces va a estar bien para tener sus menstruaciones.
Ok, la doctora.
Buenos días, gracias. Doctora, mencionó que idealmente el tratamiento o el manejo para pubertad precoz debe hacerse lo más precoz posible, ¿no? Entonces, idealmente para obtener mejores resultados antes de los 6 años. Entonces, cuando todavía están pequeñitas, ¿no? 4 o 5 años antes de llegar a esa edad, ¿qué signos o síntomas que todavía no sean muy evidentes debemos de tener en cuenta para derivarlos, ¿no? al endocrinólogo pediatra o al manejo respectivo?
Pues respondiendo a su pregunta, en realidad son los signos de pubertad antes de los 8 años. Cualquiera de los signos de la pubertad, incluso uno de los más tempranos que podemos ver es esta curva de crecimiento que iba con una curva normal y de repente entonces hace una aceleración, y esta aceleración es lo que debemos estar pendientes y muy atentos los pediatras, que puedan llevar una correcta medición de la talla en todas las consultas y puedan entonces ser acuciosos y notar esta aceleración en el crecimiento como uno de los cambios principales que se pueden observar. Y luego entonces, que una paciente que tenía un Tanner 1 de mama, en próximas consultas llega a tener un bulto mamario, un Tanner 2, entonces encender las alarmas y derivar a esta paciente para la evaluación por el ginecólogo infanto-juvenil y por el endocrino pediatra. Recordar que en estas edades tempranas, 4 a 5 años, las principales causas es el amartoma, y en estas circunstancias entonces poder realizar una resonancia magnética cerebral para poder ubicar la etiología en las niñas.
Muy bien. ¿Alguna pregunta más del auditorio? ¿Sí? ¿No hay más? Bueno, entonces vamos a dar por culminado nuestro simposio de mañana. Muchas gracias, doctores.